Welcome, everybody. My name is Marty Mascari. I'm with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center, or ADRC. The ADRC is a project of the Area Agency on Aging, and the Area Agency on Aging is under the umbrella of the North Central Texas Council of Governments here in North Texas. We're blessed here to have Dr. Ron Mottern with the Mottern Institute for Mind and Body Wellness, again, for this incredible series of webinars. Today, we're going to talk about my loved one is struggling with substance abuse disorder. What can I, or how can I help? But before we do that, if we could advance to the next slide, I'll talk a little bit about the CEUs. For those of you that are joining us today for CEUs, we're offering CEUs for licensed social workers and licensed professional counselors in the state of Texas. I've had people in the state of Texas with other licenses and people outside the state of Texas that have gotten our certificates, have said they've been able to use them. That's secondhand information. I have no way of knowing who might take those, so you're doing that at your own risk, but you're more than welcome to go through the process, get a certificate. We're also offering certificates of attendance. The guidelines are the same for both. For today's webinar, we're offering 1.5 hours of CEUs. You must complete the entire webinar live in order to be eligible. You can't miss more than about 10 minutes. We have to have the Zoom records for our documentation of who attended to back up if we're ever audited for our CEUs. You must complete the Google survey for either of the certificates, but we're also asking everybody to complete the Google survey. It should pop up as you close out a Zoom. I realize some of you have pop-up blockers. If you do, you'll receive the link to that also in the follow-up email after today's webinar. The Google survey will stay live for 1 week. And then if you would, please give us another 2 weeks after that to get the certificates out. Once again, if everyone could complete the Google survey, we'd certainly appreciate it. We use those results to report back on our funding our objectives that we set forth when we applied for the funding to do this. And so next, if you could advance the slide one more time, Doctor, I want to talk a little bit about Dr. Mottern. He's the Executive Director of the Mottern Institute for Mind Body Wellness. He has 22 years of experience in in-person and worldwide virtual treatment in cognitive restructuring, behavioral modification, emotional regulation, and physical improvement. He is a published author of Living Well, a guide to cognitive behavioral skills exercises. I know that's they have that on Amazon, and I can tell you firsthand, it's great information. And that being said, Dr. Mottern, I'm going to turn it over to you.
Okay, thank you. Thank you for having me once again here to talk about the subject of substance use disorder. This is one of those subjects that if you have 10 people talk about it, you're probably going to get 10 different perspectives on it. So today you're going to get mine. So what we want to look at as we go through this today is, first, what is substance use disorder? We'll look at the DSM-5-TR criteria for that. Look at some scoring instruments that are used for that. Then look at what is addiction, because addiction is not a diagnosis. It's not a term that's used for diagnosis. So, but that's the term that we often hear. So, what is addiction? I'll go through that. Once again, you're going to get my perspective on this. I've worked in this field for 20 years or so, more than 20 years. Gee, I'm getting old. So this is how I've approached it during this time, and we'll go over that. Sort of look at just why, the question I always get is, why do my loved ones continue to do this? Why do they continue to use alcohol and other drugs? Why do they continue to do that? Well, we'll sort of answer that in the addiction things, but just sort of go over it again briefly there. Look at substance use disorder in popular culture. Unlike some of the personality disorders that we've looked at, there's some really good stuff out there for this, and some not only entertainment things with entertainment value, even educational entertainment, which is a sort of a field in of itself, but also some educational things that you can look at that might be very informative for you. And then what can I do to help? So, you know, that's always the other question is what can I do to help my loved one with this? So that's what we're going to look at. Let's jump right in. When we look at substance use disorder, excuse me, in Texas, we're dealing with African dust and smoke from fires everywhere. So pardon me if I cough a bit. So when we talk about substance use disorder, we're looking at sort of several different things there that are in the DSM. One is substance use disorder, and then we have substance intoxication, substance withdrawal, substance-induced mental disorders, and that includes things like substance abuse psychosis, substance-induced depressive disorder, anxiety disorder, things like that. That's what you're talking about there. And then unspecified substance-related disorder. Don't know what it is. Not sure what they're on, but they're on something. So we want to look at substance use disorder as we go forward. And you can have substance use disorder mild, could be the diagnosis. You can have substance use disorder moderate or substance use disorder severe. Now, when we get to substance use disorder severe, that's generally where, if you hear somebody talk about addiction, that's generally what we're talking about is the substance use disorder severe. No hard and fast rules there, but that's generally what's going on. But if you look at these, we're going to go over these criteria in a minute, go over these symptoms, 2 or 3 of them, only 2 or 3 of them is mild. Then we have moderate, 4 to 5, and then severe, which would be 6 or more of them. We also have the clarifier of in early remission. So you can, you know, once you get a diagnosis, you have that diagnosis for life pretty much, right? It could be an early remission, which means that you've not been using for it or have been using for at least 3 months, but less than 12 months. So you have those criteria, except for the craving or strong desire urge to use. You can have that. That's not considered one of those. But, or you can have in sustained remission. Okay, so none of those criteria are around for 12 months or longer. And once again, accepting that criterion 4A, which we'll go over in a minute. So as you're looking at this, once again, any mental disorder, and substance use disorder is a mental disorder. That's the reason it's in the Diagnostic and Statistical Manual of Mental Disorders, right? That's what it's considered. Other places it may also be considered a behavioral disorder. You might also see it put in that category. But as far as the APA goes, it's a mental disorder. But like I said, you may hear it called a behavioral disorder as well. But once you get that diagnosis, it doesn't go away. Okay, maybe in sustained remission, which means you don't have any of those criteria for 2 years or more, right? At least 1 year or more, but maybe 2 years or 4 years or 8 years. But you're still going to have that diagnosis of it and in remission. This sort of ties in with many people are familiar with the 12 steps of Alcoholics Anonymous, Narcotics Anonymous, the 12-step philosophy. You know, they talk about being a recovering addict, right, or a recovering alcoholic. So they sort of exemplify that concept of, you know, I'm in recovery. It's in a sustained remission, right? I have this disorder, but it's in sustained remission. There are many different ones of these. We're not going to go over all of these, okay? So you have, in the DSM, you have alcohol-related disorders, you have caffeine-related disorders, caffeine is a drug, cannabis-related disorders, hallucinogen-related disorders, and that's phencyclidine-related disorders as well. Phencyclidine is PCP, angel dust, that's in there. Inhalant-related disorders, opioid-related disorders, which includes a lot of different things that we see these days, and then the sedative, hypnotic, or anxiolytic-related disorders. Now, an anxiolytic is a anxiety drug. So the old school stuff, Valium, Librium, Xanax, and then the new school. I mean, it's not too new, but it's newer than the other ones, right? Prozac, Paxil, Zoloft. There's several others that go in that. But when you're talking about the anxiolytics, those are the things you're talking about, people who have a problem with those. Stimulant-related disorders. This includes amphetamine, methamphetamine, cocaine, etc. Tobacco-related disorders, tobacco is a drug as well. And then other or unknown substance-related disorder, right? Now, I'm only going to pick one of these, and I'm going to pick alcohol because the rest of them are very similar in those characteristics. There may be a little bit that's different, say in the hallucinogens or the sedative hypnotics, something like that. There may be a little bit different, but in general, this is going to cover, pretty much cover all of them. You can look up the criteria for whichever specific one it is, but this is pretty much it. So the diagnostic criteria, what is a substance use disorder? Well, it's a problematic pattern of alcohol or other drug use leading to clinically significant impairment or distress. So it's causing me something that's causing me a problem, using alcohol or other drugs, and it's causing me a problem in my life. And it's manifested by at least two of the following within that 12-month period. Remember, we don't have any, from 3 to 11 months, then that's early remission, and then we have sustained remission. So remember, this is alcohol or other drugs, right? Is taken in larger amounts over a longer period of time than was intended. So did you want to stop using? Did you want to stop using and yet continue to use? Well, check that one, okay? There's a persistent desire or unsuccessful efforts to cut down. I said I was only going to do this. I tried this before. It didn't work for me. I continue to use. So we can pick that. A great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. Ever missed work because you were hungover? Might click that one, right? Craving or a strong desire or urge to use alcohol. Remember that specific one. I could not use for a year and still have a desire to use. We're not going to count that one if we're looking at remission stuff. Recurrent use of alcohol or other drugs resulting in a failure to fulfill major role obligations at work. Once again, ever missed work because you were hungover, school, couldn't make it to class, right? Or home. And oftentimes this is for a couple of days, right? We're going to look at this, that I let these things go for a few days. Continued use despite having persistent or recurrent social or interpersonal problems caused by or exacerbated by the effects of the drug. Okay, so am I continuing to have problems in my life that are caused social or interpersonal relationship problems in my life, right? Are these caused by my use? When I start to drink, do I get belligerent or things like that? If you've ever been around people who drink, oftentimes alcohol especially will affect people in many different ways, right? Some people become very quiet when they use. Other people become very belligerent and what have you. So just depends on the person and what they're using. Important social, occupational, or recreational activities are given up or reduced because of alcohol use. I used to get up and run every morning, and now, I can't do that because of, the night before, I'm not able to, or I think I'd just rather stay and sit around the pool and drink, right? Or use, or whatever it happens to be. So looking at that particular characteristic. Recurrent use in situations which is physically hazardous. Okay, ever have a DUI? Okay, that's definitely one of those. Many other things as well. But when I used to work and do assessments and what have you for this, if somebody came in with a DUI, well, that's they've got that one at any rate, right? And the fact that they're having to take time off from work and take time off from school to come in and do this, and those criteria add up pretty quickly. Use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that's likely to have been caused by or exacerbated by alcohol or other drugs. So I know that that my drinking is affecting my blood sugar, let's say, because alcohol is nothing but sugar. And so I know I have diabetes, but I continue to drink all the time. That diabetes may have been caused by alcoholism, or I may just have diabetes and continue to use. Whichever one it is, I know that it's a problem, but I continue to do it. That would be one example of that. There are other examples of that as well, right? Where I know that I'm having some physical problems in my life, but and they may be caused by that, But cirrhosis of the liver, alcohol is not the only thing that causes cirrhosis of the liver. Let me just put that out there. I've known people who have had cirrhosis who were not alcoholics. But if I know I have it and I continue to drink, then that's certainly a problem, right? I've known people who have known they've had a problem with alcohol and other drugs and yet continue to use, okay? And that means it's a problem, okay? So we check that one as well. And then the last two, when we talk about addiction, these are generally what we think of when we think about addiction is tolerance and withdrawal, right? So tolerance, I have to use more and more to get the same effect, right? Is basically what tolerance is. So it used to take me, I was drunk at 3 beers, I was getting in a buzz, and now it takes 6 for me to get a buzz, right? Or something like that. That's tolerance. That's what tolerance is. Now, let me say, you can reach a point in alcoholism where it actually starts to go the other way, okay? The liver sort of stops processing all of that, and it actually takes you less to get intoxicated than more. If you reach that stage of alcoholism, then you're in trouble, okay? You need some help. You need to stop drinking. Because you've got a real physical problem going on there. But that's tolerance, right? Tolerance is I have to use more and more to get the same effect. And then withdrawal. Okay, so withdrawal, if I don't have something to drink, then I have a problem. Let me just say this right now. Alcohol is the only drug that will kill you for lack of it. Okay, so the treatment for alcoholism is often alcohol itself. If you get to that point, you get to the point where you're having DTs, delirium tremens, and things like that, then they may have to give you alcohol to actually keep you alive. Okay. Now you may die of other stuff. I mean, if you're a heroin addict or something like that, alcohol and other drugs have a lot of ways to kill you. Okay. So, if I'm coming off of something, I'm going through withdrawal from heroin or something like that, and I have a weak heart, my heart may give out, something of that nature. There are other ways for me to die. Okay. There are other ways for it to kill me, but alcohol is the only thing that if I don't have alcohol, then that's going to be the problem. They have started using benzodiazepines, right? Xanax typically is one that's given to help with the withdrawal symptoms, but at a certain stage that I just have to have alcohol. That's it. It's sort of unique among the drugs in that way, like I said. So tolerance, withdrawal, that's generally what we talk about when we talk about addiction, but those are just 2 of the criteria. Okay. Withdrawal is an interesting subject. I don't want to get too far afield as I go through here, because I do want to leave time for people to ask questions if they've got any. But withdrawal is an interesting topic in and of itself, because we have what is withdrawal, right? Withdrawal is a reaction to something that isn't there. Okay, so it's not like I get something and have a problem with it, right? It's not like I poison myself, which is what alcohol is, right? It's poison. It's not like I poison myself and then have a reaction to that. Well, that's more intoxication, right? But the withdrawal part is that there's nothing there, but my body has become so acclimated to it that the very fact that it's not there may very well kill me. So with the subject of withdrawal is an interesting study in and of itself on this. Okay, so this is the criteria when we looked at. We needed this criterion. Refer to criterion A and B of the criteria set of alcohol withdrawal. So when we look at withdrawal, these are some of the things that we have. When we have a cessation or reduction of use that's been heavy and prolonged. Okay, that's one criteria, and then 2 or more of the following. Okay. Autonomic hyperactivity, means sweating, my pulse rate gets up greater than 100 beats per minute. Fortunately or unfortunately, mine stays that way. So I have to take a pill to try to get it below that. Not because of alcohol use, just because that's the way it is. Increase in hand tremors, insomnia, nausea, vomiting, transient visual, tactile, or auditory hallucinations or illusions That's the word from the DSM-5. You would expect delusions, perhaps, but no, it's hallucinations or illusions. Psychomotor agitation, anxiety, tonic-clonic seizures, things of that nature. Anytime I have 2 or more of those, heavy, prolonged use as well, then we will diagnose withdrawal, right? Okay. Let me talk just a little bit about the genetics of this. You know, there is a genetic component to drug use. Okay, moving on from sort of alcohol itself, right? We're talking about alcohol and other drugs, right? But there is a genetic component to that. But let me remind you that there is no genetic component that makes me use. Okay, and people often get confused about this. Genetics don't work that way. Okay, there is nothing in my genes that makes me go out and do something. Okay. We'll may talk a little bit about this next time when we're here, when we look at antisocial personality disorder, right? There's nothing in my genes that causes me to use. However, if I use, then I may be genetically predisposed to use more, okay? And this is what we talk about when we talk about genetic high responders and low responders. So a high responder, it takes less to become intoxicated off of something. Okay, it takes me less of it to get high, and the reason that's a high responder is I'm responding highly to whatever it is, right? So it takes less of it. A genetic low responder, it takes more of it to get me intoxicated. Now, which one would you think would be more likely to become, addicted to something? Using that term, addicted. It's the genetic low responder, right? Because I can use more and more of it without having a problem. So I use more and more of it. My body becomes acclimated to it. That's when I really have to start worrying about tolerance, withdrawal. Certain physical structures in the body actually change, right? Because of that. So the low responders is not good. Okay, high responder, I have 1 beer and I'm drunk. Okay, well, guess what? I'm probably not going to drink very much. If I know that it does that to me, I'm probably just going to stay away from it. However, if it takes me 10 before I get drunk, well, I have all the effects of that alcohol on my body, not necessarily to get intoxicated, but just the effects of the alcohol on my body. But then also, I'm going to be using more and more of that in order to get that intoxication. So there is a genetic component of that. It can be a genetic high responder or a low responder. But remember that nothing in my genes causes me to go out and use. I have to use first. So, stay away from it. Stay away from it. Okay. The one time you use or the one drug you use may be it for you. Okay. I use it. I liked it so much I became addicted to it. Right. And this is often what I hear. This is often what I hear from clients and what have you, is that so why do you use, right? Why do you use? Well, I like it. Okay, it feels good. I like to do it. Okay, not everybody is trying to escape some horrible past. Now, there's plenty of that out there. Don't get me wrong. Plenty of people have had some very traumatic past, and you really understand why they would want to use, because they don't want to deal with that. But other people, it's fun. I just like to do it. Okay? I usually get this from the meth addicts. Okay. Who the stimulants cause a spike in the body. We'll talk about that in a minute. But so the one time I use it may be too late for me. So abstinence is the best thing, right? Don't experiment. Okay, you don't need to use it. Get high on life. Go into some flow activities, things like this. Find something else to do, because it may just be that one that causes it. Okay. Okay. As far as scoring instrument goes, there's lots and lots and lots of them out there. These are a few. I just want to throw these out there. One is the SASI for the Substance Abuse Subtle Screening Inventory. Has an accuracy of about 92%, validity rate of 92%. So it's well used. It's been used for a long time. We've gone through 4 incarnations of it now. They have a Hispanic version of it as well. I think they have an adolescent version of it too that you can use, but the SASE is one that I've used extensively. They have that used to be pencil and paper, and you can still do it pencil and paper, but they also have an online thing you can do these days. And these are a few of these things that are just very simple to go through, right? I often get the question, am I an alcoholic? Am I an addict? Well, okay, you have the DSM criteria. Go through those, right? I mean, go through those. See if you hit some of those. You still want to know? Take one of these, right? The Michigan Alcohol Screening Test, the MAST, is 25 questions. Takes 3 minutes to do, and I gave you a link there. Okay, you can go to link and you can do it. Just do it online. Take you 3 minutes or less to just do it online. It'll give you a result and tell you you may be chemically dependent. You may have a substance use disorder. Then there's the SMAST, which is the short Michigan, which is only 13 questions and takes about 2 minutes. Both of those are on that same site. It has a couple of other things on there as well. So you may take a look at that if you're interested. And then those two are just for alcohol, but they do have the drug abuse screen test, the DAST-10, which is, I don't think it's on that site. I couldn't find it on that site, but that it is out there. So just very simple little things. You don't have to have a degree in order to look at these things and tell. The SASE, you do have to have training in the interpretation and the scoring of the SASE. There's a specific way you have to give it. It's a two-sided test. One side you have to give before you give the other side. And then they have an interpretation. How do you interpret the results and what have you? But as far as the MAST, the SMAST, and the DAST go, you just fill them out, add them up, and it'll give you a diagnosis. Not really a diagnosis. It'll tell you if maybe you have a problem. Let me just throw in that whatever scoring instrument you use, it's worthless unless you have a follow-up interview after it. Okay, so you always want to look at something like the SASE, right? We fill that out. The SASE has what's called a defensiveness scale on it. So you score 8 or more on that, means you're being defensive, and the answers of the test may not be accurate. So it really helps to go back over things like that in the interview afterwards, and ask for this particular question, why did you answer it this way, or what did you mean? What did you think the question meant when you did that? So it helps clarify some things when you go back and do the assessment after, do the personal assessment after the scoring instrument itself. Once again, there are lots of those out there. If you're a professional, if you use something like the PAI, Personality Assessment Inventory, that has a substance use component to it. So it'll tell you as well if you use something like that. So, if I don't know why you would be using the MMPI outside of a psych facility, but if you're using the MMPI, that'll tell you. Okay, if you want to do all 400 and some questions, have people do 400 and some questions on it, it'll also tell you. So there are other scoring instruments that you can use. These are just some very simple ones, some very common ones that are out there. The SASE, like I said, has been in use for a very long time, has a good validity on it. So, and also, if you have a question on it, you can just call them and ask them, and they'll get back to you on that. The other ones can help you look at it, but you always have to have the interview. You always have to follow up with that. Okay, so now we get to my part. Okay, so what is addiction? Okay, like I said before, oftentimes if we get substance use disorder severe, we'll talk about that addiction, but addiction is not terminology that's used in the DSM. Okay, it's something that you may use in practice, but it's not used really in diagnosis, right? It's not the lingo that you're going to use in diagnosis. So what is addiction? Well, I mean, addiction is I want to stop, but I keep doing the same thing over and over again, right? Well, why do I do that, right? This sort of goes into that question of why do I keep doing this over and over again? I just talked to a client recently who relapsed, and that was their exact words was, after I use, I realize how stupid I was. After I use, I realize that I shouldn't have done this, that I shouldn't have done that. Why do I keep doing these things? Well, there's a reason for that. Okay. And to explain the reason, I need to go into choice theory psychology a bit. Excuse me. Okay. So choice theory psychology, basis for reality therapy. And choice theory psychology says that we all have 5 basic genetic needs. Okay. We have the physical need of survival. That's food, water, heat, air, right? We have to have all of those things. And then we have the psychological needs. And the psychological needs are love and belonging. And these are not term specific, they're need specific. So anything synonymous with these terms is going to fit in there. So anything synonymous with love and belonging, to cared for, to care for others, anything like that, we're talking about the same need, okay? So power, recognition, achievement, control, respect, all of those talking about the same need. Fun, learning, excitement, creativity, all of those are the same need. Freedom, independence, choice, autonomy, all of those fall under the same need. So we have those 4 psychological needs, and we have the 1 survival need. Now, those needs are first and foremost motivators. They motivate us to do everything that we do, which I think is what that they is right there. We don't do anything as a pattern of behavior that doesn't fulfill at least one of those basic needs, okay? If we try something, it doesn't do anything for us, it doesn't fulfill our needs, then we just try something else. We just move on to something else until we find something that we like, okay? Now remember that we're motivated by pleasure and pain, right? Those are physical, the pain and pleasure, that's what motivates us. Pain motivates us to stop doing whatever it is we're doing, right? Stick your hand on a hot stove, ouch, don't do that again, right? I don't want to do it, it hurts. Pleasure motivates us to continue to do something, okay? This is what orgasm is, right? Orgasm, is survival of the species, okay? And it feels good. We want to do it more and more and more and more, right? We want to propagate the species as we go out. So pleasure and pain, those are physical things. The psychological needs are what motivate us are happiness and misery, okay? So those are sort of the psychological components of that. Happiness and pleasure, and then misery and pain. Happiness and pleasure are not the same thing, okay? If you don't know that, by now you need to do some reading in philosophy, okay? But pleasure is physiological, right? Happiness, I may have to forego physical pleasure in order to achieve psychological happiness, okay? So pleasure, pain, happiness, misery, these are the things that motivate us. And when we meet these needs, when we meet any of these basic needs, we feel pleasure or happiness, okay, depending on whether it's the physical need or the psychological needs. So we feel pleasure, so we want to keep doing whatever that is that causes us that feeling of happiness or feeling of pleasure. If we meet any of the physical needs, like once again, food, water, heat, air, right? Those also feel pleasure, we feel happiness, we want to continue to do those things. When the needs are not met, then we feel pain or we feel misery. That's psychological misery. If I don't get my needs met, I will feel miserable, okay? So those needs, once again, first and foremost, motivators. They motivate us to do everything that we can do through this pleasure, pain, happiness, misery sort of setup that we have. Now, I said that the needs are genetic, okay? We all have them, and we have them at various levels. And whatever level they're at. It does not change over time, okay? Now, some people have questioned, well, does it change in adolescence? Does it change in midlife? There seems to be, changes in our lifestyle, things like that. No, it doesn't really change. What happens is at those particular times, we just tend to get better or worse at meeting our needs. What was working for us before no longer works for us, or we find other ways to meet our needs. So the level, whatever level it's at. And you can do a basic needs profile. Just put it on a scale of 1 to 5, right? It can't be 0 because we all have these needs. So it's on a scale of 1 to 5. It just comes out 0 to 6 on this thing. I can't figure it out how to get it from 1 to 5, but 1 to 5 on that, and say, so where is it? Where do we fit on that? My survival need may be at a 4, right? My love, longing, maybe that's a 3. Okay. Power, recognition, achievement, maybe at a 2. Fun, learning, excitement, that may be all the way up there at a 5. Do not think that survival is the biggest need, because it is not. Survival is one of the 5 basic needs. For you, it may be the biggest need, but not for everyone. There's a lot of people who kill themselves yesterday and will kill themselves today, unfortunately, because that survival need is not the biggest need that I have. Freedom may be down there at a 1, right? So whatever level it's at, okay? Now, even though they're set at this level, remember that in the moment they can feel very different. So this is why they're motivators, okay? Because they cause us to do things to try to get them met. So for example, if I'm not having fun right now, and that's a big need for me, right? If I'm not getting excited about Dr. Mottern's presentation, then I want to go someplace else and I want to do something else, right? And I may do that, right? And then pop back up at the end so I can log on. But anyway, fill out the thing. But anyway, that fun need is high there. So if I'm not having fun, I'm going to find something to do that. In actuality, my genetic need for fun is at a 5, but right now it's at a 3, right? It feels like it's at a 3. The need doesn't change, but the perception of it changed. So it feels like it's at a 3 and it should be at a 5. So I'm motivated to do something to meet that need. Okay. Now I can have more than I want. I could have a 5's worth of freedom and it doesn't matter to me because I only have to have one of it. But survival, food, water, heat, air, right? If I think I'm not getting enough food, I will. Well, think about the survival. Let's take a look at the survival needs versus the psychological needs. Okay, let's take the survival needs, right? Food, water, heat, air. The biggest of those is what? The biggest of those is air. I can only live 3 to 5 minutes without air. However, when's the last time you thought about breathing? We usually don't, because it's part of the autonomic nervous system. I breathe automatically, so I don't think about it. Okay. Now, if Chuck Norris was to jump out and throw a chokehold on you, all of a sudden that need for oxygen may, exert itself, right? So I feel that need very strongly. So the next one that we have, the next biggest one, the first one is oxygen. The second one would be water, right? I can only live 3 to 5 days without water, and that's pushing it, more like 2 to 3 probably, but 3 to 5 days without water. Okay. And then food, right? I can live 3 to 5 weeks without food. Okay. Some of us a little longer, maybe pushing the 5 there, but then we have the food. Okay. So that would be the next biggest one. And then heat would be the last one, as long as we're not in hypothermia or something. We're endothermic mammals. We create our own heat. Okay, as long as we're not out in the elements somewhere and freezing, we don't have to worry about that. So that need for food may be one of the lowest, right? It's the third one of all of those. Okay, so that need for food may not be very strong. But if I'm fasting, right? If I had to do some blood work this afternoon, and I've been fasting since midnight last night, where did you think that will seem to be? That need for food may seem to be much higher than it actually is. Okay, it may seem to be up there at a 5 right now, even though within the order, it's never going to be, my need for food is never going to be higher than my need for oxygen. My need for water is never going to be higher than my need for oxygen. I may be dehydrated and dying of thirst in the desert, but if you cut off my oxygen, that's where my mind is going to go. I'm going to think about that first. I'm going to forget about the water, and I'm going to want the oxygen. It's the same thing with the psychological needs. Okay, they're set wherever they are. But if I'm not getting them met at that time, they may seem to be higher. That's what motivates us to do something to get that need met. Okay. I hope I've explained that to where we get that. Okay. Whatever level they're at, the level doesn't change, but what motivates us is that they seem like they're different places. I may be on here giving a presentation, and my need for recognition may be, up at least a 2, or maybe a 5, or whatever it happens to be. But when I get through, my wife is say, "Hey, Doc, take out the garbage," right? So, okay, well, it's not so high then, so maybe I need to do something to get it back up again. So it's set permanently where it is. But as we go through our day, it feels like it rises and falls. Okay, that's the motivation part of that. Okay, now in actuality, we don't, prior to today, you may have never heard about these needs before. We don't talk much about the needs. They're the genetic part. We don't directly access them. But what we do talk about and what we do directly access is our wants. The wants are a reflection of our needs. I want this, I want that. I want those things because I think they will meet those needs for me. I think they'll fulfill those needs. As we do things, or as we acquire things, things that get us what we want and meet our needs, they get to be what are called pictures in the quality world. Now, the quality world is sort of like a mental mosaic that's there. It's like a picture album. The pictures of those things that meet our needs get to be in that picture album. Okay. Bad part is, okay, once a picture gets into my quality world, it's there forever. Okay, it does not go away. So over time, if I'm not meeting the need, then over time, then the need will begin to fade, just like a photograph. It'll always be there. For example, think about your first love you ever had. Okay, still remember them? Okay, you may be married to somebody else, and you may have been happily married for 30 years, but you can still remember that first one. Okay, you may not have the emotions attached to it anymore, right? Those aren't there, but the picture still is. The picture is still there. This is what fulfilled that need for me at that time. Over time, it's faded out. Okay, it's sort of gone from color to black and white. Okay, but it's still there. And that's because when we talk about the quality world, really what we're talking about is long-term memory. Okay, so once a picture gets in that quality world, fulfills our needs in some way, gets to be a picture in our quality world, it's there forever. And when we talk about alcohol and other drugs, that's bad, because once a picture of alcohol and other drugs gets into the quality world, it is there forever. Now, how does a picture of alcohol and other drugs get to be in my quality world? One of 2 ways. Okay, one way is it actually meets my needs. So we have those psychological needs. It meets the needs. Think about that old show. You may remember Cheers, right? You may remember that show. Okay. Fat guy walks into the bar. Everybody yells, "Norm," right? So what need is met for that? Certainly recognition. Everybody knows his name. That was sort of the theme song, I think, for that, where everybody knows your name, right? You go to this place, you sit there, you drink beer with your buddies, you get your need met for recognition. Now, other needs may be met as well. Usually through most of the things we do, we meet more than one need. So I go to the bar, everybody knows my name, I'm there. When Norm was at the bar, did he have fun? Seemed to. I mean, that's what the sort of the show was about, right? Sort of it was a comedy. So he had some fun situations. So he got his need for fun and learning met. Okay, he got the need for learning, that aspect of learning, because of his friend Cliff, right? The postman who knew everything. Right, so he sort of got that filled there. The need for freedom, he got that filled because his wife Vera was always looking for him. Right, she's always calling the bar. Vera's calling, and he's there. Right, so he gets freedom away from his wife. So all of those needs are sort of met by going and doing these things. Now, if I spend enough time at the bar drinking beer, might I develop a problem? It's possible, especially if I'm a genetic low responder, right? Might develop a problem there. So that's where one way that it can get to be a picture. Me going to the bar drinking can get to be a picture in my quality world. Another way, the need for belonging, this closeness together. IV drug users are a very tight-knit little group. Okay, they know each other, and they, not only that, but they have sort of this sense of recognition that we're the real drug users. The rest of you are just sort of amateurs, which goes on. But you know, so they have that sort of thinking going on, but it meets their needs. Okay, it fulfills that need. So why do they keep doing it? Because it fulfills the need. Okay, that's the reason I do it. Remember, if I don't do it, what am I going to feel? I'm going to feel misery. I'm going to feel pain, right? So if I do these things, it causes me to feel pleasure. Now, one way is it meets the basic needs, right? The other way alcohol and other drugs get through there is because it fools the brain into thinking that the needs are actually met. When I use drugs, am I actually fulfilling my need? Or let me restate that. Does the drug itself, which causes these feelings, actually fulfill my need? No, the drug itself does not fulfill your need, but it causes that feeling of pleasure, okay? And that makes me think that my needs are being met because I have that feeling of pleasure. And because if I don't do it, I may have that feeling of pain and misery in my life. So alcohol and other drugs get to be a picture in the quality world in one of two ways. One way is they meet one or more of those basic needs, okay? Gets to be a picture in my quality world. Once it's there forever. This sort of ties in with the 12-step philosophy, you know, that I'm a recovering addict, I'm a recovering alcoholic, okay? That picture is going to be in there forever, okay? I may have other things that I put into my life that are brighter and more colorful, and that one begins to fade, but it's still there. Second way is it fools the brain into thinking that their needs are being met by this feeling, by causing this feeling of pleasure. Okay, so that's how the picture of alcohol and other drugs gets into the quality world, and once it's there forever. Now, there's something called, we have something called the hedonic set point. Hedonia is pleasure, right? And I'm sorry for this graph. This is the best I could do with smart art on there. I usually just draw it on a board, right? So you just have a graph there. And as we do things, so this bottom one, this orange one right here, I don't know if you can see my pointer, but this orange one right here, as we do things in our life, we'll come to that certain point where the pleasure will sort of peak. And where that pleasure sort of peaks, that's the hedonic set point, okay? So for most people, the biggest pleasures we have in life are food and sex, okay? Those are both tied into survival. They're both tied into other things as well, with other psychological needs, but food and sex are it. So I peak here at, you know, at sex, I peak over here, I had a good steak and lobster or whatever it was. Okay, so that's the hedonic set point. So here it's about 5, right? It's between 4 and 6, so it's about 5, let's say. That's the hedonic set point. The pleasure goes up to there, so we can say that's the set point. When I use something like meth, okay, methamphetamines is about 40 times more powerful than the best food or sex you're ever going to have. Okay, so what happens? Boom, all of a sudden that pleasure shoots up to a 10, right? Or a 20 or whatever it happens to be. Okay, it shoots all the way up to that point. And then it'll come down, and you'll notice that as it comes down, it goes below generally the lowest that I usually experience. This is especially something with cocaine, right? When I coming off cocaine, I go down below my lowest, so I have to use to get back up again. But with cocaine being a stimulant, so most of the stimulants act the same way. Meth being especially powerful on this. But once again, I use that, it goes up, and if I keep using, at some point, that hedonic set point will move. It will move from 5 up to 10. And once that hedonic set point moves up to 10, remember that I can't experience any pleasure on anything really below that, okay? So what does that tell me? That tells me that unless I use, I'm going to experience no pleasure in my life, okay? Now, the good news is that after I quit for a while, right, the hedonic set point will drop back down. This is the process of what's called allostasis. It's the same thing with the temperature in the body, right? It's the same thing. Temperature goes up to fight the infection, what have you, and then it'll drop back down after the infection's gone. So sort of the same thing with the hedonic set point. As I continue to use and use and use, that pleasure thing goes up. When I stop using, it's not going to go that high anymore. It's not going to get that high. The best food or sex I'm going to have is not going to be nearly close to what that is. But over time, if I stop using, then the hedonic set point will drop back down to the 5 level and drop back down to where it normally is. Now, there is another thing that, dopamine is what causes that feeling of pleasure and what have you in our lives. And you can use so much that you burn out the dopamine. The dopamine production at some point is producing so much dopamine, at some point it says enough and just shuts down. Okay. At that point, I'm screwed because I can't, once that happens, it's done. I can't experience pleasure anymore. It doesn't matter how long I wait. It's not going to kick back on. Okay. And I've known a few people over the years who have unfortunately got to that point. Now, let me say, we do have some, medication treatments and things like that, some medical treatments that tend to that will try to rehabilitate the dopaminergic system in the body and what have you, and get people where they can actually experience some sort of pleasure. But when your dopamine system shuts down, you're in bad shape. Okay. So anyway, so the hedonic set point, once again, hedonia is pleasure, right? So that's the pleasure thing. So if I use methamphetamines and it causes me to feel so much pleasure, really what's that telling me? From an evolutionary standpoint, that's telling me this is what you need to be doing because this is good. Now, if we were animals, we could understand that, right? That's the reason we have a frontal lobe, okay? Unfortunately, the frontal lobe often shuts down when we use these things. And that's the reason we continue to use, right? So that's really what addiction is, right? Alcohol and other drugs gets to be a picture in my quality world because when I use, it causes me pleasure. It causes me feelings of happiness. Okay. And when I don't use, it causes me withdrawal or it causes me feelings of misery, something else. And so evolutionarily, what it's telling me is continue to use. So one of two ways, either what I'm doing, the very act of using fulfills those needs for me, or the drug itself fools the brain into thinking that the needs are being met. So the behaviors and the drug itself can both get to be pictures in my quality world. And that's the reason I continue to use over and over again. Because if I stop, I'm going to be miserable and I'm going to be in pain. And, we tend not to like those things. We tend to like the things that do. So the question becomes, so how do you help somebody then? Is there a way out of this? Are we screwed forever? No, we're not. There is ways out of it. We find other ways to meet our needs besides alcohol and other drugs, right? We find other pictures to put in our quality world. And when given a choice between drugs or the other picture, we choose the other picture, okay? It's always going to come down to a choice. There's never a time it's not going to be a choice, okay? I have to choose the other picture. I have to choose whatever the other picture is that's going to give me pleasure. Now, is it going to be as good as the dope? Probably not, but it's going to give me some of that, okay? This is what, this is what 12-step groups are not only very popular, but also the last research on them, they had a pretty good success rate with 12-step groups. And that was at the 12-step groups, you can get your needs met, okay? You can get that need for belonging met because you're there with a group of people who are struggling with the same thing that you are, okay? So that meets the belonging need. You can get recognition needs met. You go one day without using. Okay, you get a nice shiny little chip. Everybody cheers you, so you get that met. Longer times, you get longer periods of that. I can have fun at 12-step groups. They do everything. They have barbecues, dances, everything everybody else does. They just do it clean and sober, right? So I can get that need met. Freedom, I can certainly get my freedom need met there. They'll tell you if you don't want to be here, then don't come. Okay, don't show up. So I can get all of those needs met at those groups, which sort of explains the success of those. But that's what we want to do. We want to find other pictures to put in our quality world. And then when it becomes a choice to where, I really want to use, I really need to get this need met, I want to draw on those other pictures, okay? I want to choose those other pictures. And over time, what will happen as I continue to make that choice, I explained this a minute ago, but as I continue to make those choices for those other pictures become brighter and the picture of alcohol and other drugs becomes dimmer. So eventually, what's the first thing I think of? I think of these things. I don't think of using. Okay. And people with long-term sobriety, will tell you that, when, long-term sobriety, something happens in my life, I don't even think about using anymore. I think about this. Okay. This is what I'm thinking about. I'm not thinking about using anymore. If I think long enough, is that picture still there? Yeah. But why do I want to do that? I want to focus on this. Okay. So this is my take on it. Like I said. Okay, so some substance use disorder in popular culture. Now, there are many, many more movies than this out there. These are just some that I'm familiar with, some quality movies that if you want some enjoyment and you want to sort of, once again, some educational entertainment there, so I'm being educated about something, but I'm also enjoying it and having a fun time doing it. So fun and learning go together, right? They're the same need. I'd be remiss if I didn't throw that first one in there. My name is Bill W. It's the story of Bill Wilson, the founder of AA. James Woods plays the title character in that. It's from 1989, sort of an old movie, but it's a good one. It explains the whole process, what he went through in his life, the sort of where that movement came from. If you want a comedy, okay, Skin Deep is one of my favorites. And it's a Blake Edwards comedy. If you're familiar with Blake Edwards and you like his stuff, then this might be for you. Other people, not so much. But Skin Deep this guy has a problem. Okay, part of it is he's an alcoholic. Okay, but he also has what we might call a cross addiction with he likes women. Okay, and so all of that is getting him into trouble. And he is a man with problems, with severe problems in his life, but it's presented in a this is a comedy, so it's presented in a very humorous way. John Ritter's in it, like I said, so I like it because fun and learning go together, and this tells a lot about what people have to go through. Another one, very serious movie, very dramatic picture is When a Man Loves a Woman. Meg Ryan, Andy Garcia are in that. Meg Ryan is the alcoholic in that movie. Good movie. Leaving Las Vegas with Nicolas Cage. This is about a man who's had lifelong problems with alcohol and goes to Las Vegas to drink himself to death. Okay, and then sort of follows that from there. This is one, just as Skin Deep is a comedy, Before the Devil Knows You're Dead is not a comedy. Okay, this is Sidney Lumet was the director of this. I don't know if you're familiar with his work. He did things like Serpico and Q&A and things like this. So he makes very gritty, realistic movies. And this is a gritty, real. Do not watch this movie if you're in a bad place. Okay, this is not a feel-good movie. Let me tell you that right now. But it does show just how addiction, just how substance use disorder can affect people's lives in horrible ways, in very bad ways, just tear families apart and what have you. Ethan Hawke's in it. There's just several other well-known actors that are in it as well. Like I said, very gritty drama. It's a very good movie, but it's not a feel-good movie. Pick your day on watching that. Flight is one. Denzel Washington. This was based on the true story of a pilot who there was a mid-air sort of problem, and he performed some miraculous moves to get him through, to get everybody on the ground safely. But as it turns out, he had alcohol in his system, and he was indeed an alcoholic. So that caused him many, many problems in his life and what have you. So once again, a good movie. Now, if you want some just educational stuff that I don't understand addiction. I don't understand this problem. I want something to look at that'll help me understand it. These are the movies to do. Number one, Omar and Pete. Okay, 2005 documentary by Todd Lending. This is an excellent movie. It's about two guys who get out of the Baltimore State Penitentiary. They go into sort of a three-quarter-way house, go into a community program. They have to report to their POs. They have to hold the job, these sorts of things as they go through. Not to throw any spoilers in there, but one person does very well and one person does not do very well. And this is something to look at to say, why does this person succeed and why does this person not succeed? Now, I've showed this before to populations. They said, oh, this guy was institutionalized. It's like, no, can't do that. Both of them were in prison for 25 years. Okay. They both knew each other in prison. They both came from the same place. They both were dealers on the same street. Okay. You can't get much closer than these two guys as far as demographics and history and everything else. So why does one person make it and one person doesn't do so? One person is now still in prison. Okay. And what you'll find is that this is based on the choices they make in their lives. Okay. So once again, back to choices and consequences, but Omar and Pete is an excellent documentary. HBO had a documentary series from 2007 called Addiction. Many of you might have seen that. That has some good parts in it. I don't like all of them, but it has some good ones. It has a night in Parkland Hospital and up in Dallas, where they one thing I believe they bring in again. One of the scenarios is a guy comes in on a motorcycle from a motorcycle wreck and ends up dying. I mean, this is a documentary, right? So fortunately, the guy passes away, but he did have cannabis in his system when they did that. Okay, so he was under the influence of drugs when he had his motorcycle crash. Let me tell you right now, alcohol and other drugs have more than one way to kill you. Okay, you may not die of an overdose, okay, but you might very well die because your reflexes were somewhat retarded and you weren't able to avoid that, whatever it was that caused this guy to crash his motorcycle and then end up dying. Okay. You may drink so much or use so much that you pass out, and that cigarette that falls on the floor catches your apartment on fire and you wake up dead because you burned up in fire. There is a lot of ways that that alcohol and drug substance use disorder has to kill you, right? I mean, that's the progression of the illness is generally, jail, institutions, death, right? That's it. So jail, I'm doing something that's getting me in trouble with the law, whether it's DUI or whatever it is, possession, controlled substance, whatever it is, get in trouble with the law. And then institutions, I'm in, psychiatric institution, treatment facility of some sort trying to deal with this. And if that doesn't work, then I end up dead. Now, let me just say that process can go on for a number of years, right? That can go on for 20 years, or that can be very precipitous, right? That can go on and you can jump straight from nothing to death without going through the other two. Another documentary that's out there that sort of lends itself to that, National Geographic, I believe it was National Geographic, yes, that did a video called the World's Most Dangerous Drug. Okay, now the drug they were talking about was meth. Methamphetamine. Those of you who've worked in substance abuse sort of chuckle at that, I'm sure, because we all know that the world's most dangerous drug is whatever drug it is you're addicted to. Okay, that's the one that you got to worry about. That's the most dangerous drug. So there's that. But they did one documentary on meth where this high school couple, they were seniors in high school. They went to a party. They were up in North Dakota, I think. They were someplace where it was cold and not a lot of people around. One of those northern states. Maybe Minnesota. We have somebody here in Minnesota. Maybe they remember it. I don't know. I think it may have been North Dakota or something. Anyway, they go to this party. They use meth for the first time, and then they leave, and they die. And the reason they die is because they get lost. Okay, they don't know where they are. They call the police. They have phones. They call the police and say, this is where we are. We're on this street. We're here. Well, they're not in the same town. Okay. They're not in the same town. They're telling the police they're at this street. The police are like, we're here. There's nobody here. Where are, describe the things that are around you. They start hallucinating. Oh, there's people after us. There's people on top of the car. None of that was happening. Okay. They were tripping on the meth. Okay. And they ended up, they both ended up freezing to death because it was very cold up there. And just because they were high. It was the first time they'd ever used it, and it was the last time they ever used it. So you can go through that, you can jump straight to death. You don't have to go through the jails and the institutions to get there. But anyway, addiction, like I said, has some good things in there, some good segments of it. I don't care for all of them, like I said, but it's a good watch. And then there's one called Pleasure Unwoven by Kevin McCauley. Pleasure Unwoven, if you want to know the physiologically what happens in addiction, okay? Substance use disorder, severe addiction. If you want to know what happens physiologically, this is the tape for you. So McCauley has some personal experience with that. He used to be a Navy doctor. He used to be a doctor for naval aviators, okay, until he started writing himself prescriptions. And the Navy didn't take kindly to that. And so he had some problems. He then came out and had some problems with the court systems outside of there and what have you, and apparently got himself back straight and clean and sober. And so he made the movie Pleasure Unwoven. It's a good film, like I said, about physiologically what happens in addiction. So that's another one out there you can see. All right. So what can I do to help? Okay. Number one, do not support their use. And, you know, when I wrote this, what can I do? I'm looking at, you know, a loved one, right? This is what our title is anyway. So I'm a loved one. I have a family member. What can I do to help? Do not support their use. Okay. You know, I need money for food. I need money to buy milk or whatever it happens to be. Okay. I'll go get the milk for you. Okay. But I'm not going to give you the money, because if I give you money, I know exactly where it's going. It's going to drugs. Okay. So do not support their use. Okay. Number one. Number two, set firm boundaries and don't relax them. I mean, you have to have firm boundaries on this. This is our life. You don't, you know, this is our house. You don't use in our house. Okay. It's that if you use in our house, you have to leave. And, you know, if they use in the house, then they need to leave. That's it. You know, well, where am I going to sleep? What am I going to do? Not my problem. Okay. You had the choice to not use or use. You chose to use. So you need to go to the shelter. You know, I'll give you a ride to the shelter if you want to go to the shelter. But you got to go. Can't stay here. Encourage them to seek treatment. Okay. We know that those people who, you know, coerce them as much as you can. We know that people in coerced treatment tend to do better than people who are non-coerced treatment. But you know, coerce them however you can, encourage them to seek treatment. Can't make them get better, can't make them make better choices, but try to get them at least in treatment. What we know is that at some point, if people live long enough and they have enough treatment, at some point there tends to be a critical mass where everything that they've learned over the years takes. Okay. Some people, it takes very quickly, right? Doesn't take much treatment at all. Other people may take a lifetime of it before they get there, if they live that long. But so the more treatment they can get, then the better it is. Don't pay for it. Okay. You got insurance or something like that, but let them pay for it. But have them seek treatment. Don't give up on them. Okay. You know, they're going to train you over the years to react to them in certain ways. And this sort of talks about the next one as well. But try to avoid that. Okay. Don't give up on them. You can get very upset at people, especially because they're people we care about, right? We get upset about people we care about. If I didn't care about you, I wouldn't get upset. Right? I wouldn't care about you. But so we get upset about the people we care about, but don't give up on them, because sooner or later that critical mass may hit and they may get it. Okay. So, you know, have hope for them, pray for them, you know, if you do that, but, you know, don't support their use, don't allow them to break your boundaries, have them seek treatment, and don't give up on them. Always keep open for them. Once again, understand that they've trained you to respond to them in certain ways. So be aware of this. When they enter recovery, they're going to do or say certain things, and you're going to be like, no, I'm not falling for that. Okay, we've done this before. I'm not falling for this again. That may not be the case. They may, you know, I need $10 to pay for my bus pass so I can get to work. If you could loan me the $10. No, I'm not doing it. I know this you're going to use. Well, before they may have. Once they're in recovery, maybe not, but they have trained you to think that way. So you might look at it more objectively if you can and say, okay, well, he's been doing very well. He's holding down a job now. Okay. I know he's there because I see him when I pass or when I go by. And so I know he's doing that. I don't think he's using, so I might trust him to use this. Okay. So they'll have to buy that trust back a little bit at a time, right? They're going to have to earn that trust back a little bit at a time. But just beware that they've trained you to think about them in a certain way. So, and that may not always be accurate. Okay. Now it's their fault. They trained you to think that way, but it may not always be accurate, especially when they're in recovery. Ask about their relapse prevention plan. A man without a plan is not a man. Okay. And then I think it was Nietzsche who said that right before they hauled him off to the insane asylum. But anyway, we have the 5 P's. They're usually the 6 P's, but today we'll do the 5 P's. Previous planning prevents poor performance. Everybody who is in recovery needs a relapse prevention plan that looks at their relapse triggers and the areas of people, places, and things and what to do about it. They need to know who to call if they get in trouble, whether it's their sponsor at a 12-step group, whether it's somebody else who's supportive, whatever it is. They need that written down with their name and their phone number and everything else that they can access it very easily. And they need to carry it with them, but they need to have a plan. And then, you're going through a lot. If you have to deal with this, then you've got your own problems, okay? Dealing with this. You have your own set of issues just because you have to deal with it. Seek therapy as you need it, right? If you need to go talk to a counselor, learn some stress management techniques, excuse me, stuff like that, please do, okay? Because you need to stay well yourself. Okay. So there's some references. There's my contact information. Okay. Any questions? Any questions?
There's a few things that people have put in the chat. Why don't I? How about if I go through the CEU stuff again while you look through the chat? Is that fair enough?
Okay.
Hey, can we advance it to the next slide and then we'll put it back on your contact information, if that's all right. Yeah, just for those of you that are joining today for CEUs, we're providing CEUs for licensed professional counselors and social workers in the state of Texas. You can also get a certificate of attendance. Go ahead.
Sorry about that.
You go right ahead. What do you need?
No, I cut the screen off there.
Oh no, it didn't do it to us. So I'm not sure what it did to you. We're still showing, so we're good. So so in order to get the CEUs or the certificates of attendance, you must have completed the entire live webinar. You must also complete the Google survey evaluation that'll pop up when you close out of Zoom. If it doesn't pop up, you'll also receive the link in the follow-up email. We're asking everybody to complete the survey, please, but you must complete it to get a certificate. The evaluation will be up and live for 1 week from today. So you need to do it before then. And then please give us 2 weeks after that to get the certificates out to you. So I'm going to turn it back over to you, Doctor. I'm going to ask if we can back the slide up one, if possible, and let's leave your contact information up if we could while you're answering questions so people can have that. I'll also include that in the follow-up email as well. There you go.
Okay. All right. Okay. Oh, sorry.
That's all right.
Okay. Sounds unrealistic. Well, it's worked for me for 20 years. So talk to somebody else. They'll give you another view on it. Yeah, they give you the first little bit for free. Yeah, that's right. Yeah, that's the marketing ploy, right? Can motivation lead to lack of patience? Yes, lack of patience is frustration, right? And that's what happens anytime that our needs aren't met. We get a physiological feeling of frustration. Okay, so yes, indeed, that's what happens. How can I better explain loved one with SUD who's alcohol to help us sleep? Well, number one, alcohol does not help us sleep. In fact, alcohol disrupts the sleep cycle and helps you not sleep very well. In fact, if they're using alcohol to help with sleep, that may be why they continue to have a problem with it. because it doesn't help us sleep. Now, if I'm just worn out, if I'm worn out all day long and I have a drink when I get home, will I go to sleep? Probably. But if I'm drinking, several drinks to try to help me with sleep, that's not helping me. That's actually causing my problem. The name of the movie that was tough to watch was Before the Devil Knows You're Dead. Okay. Yes, retarded meaning it doesn't move forward, right? We're not discussing people here. Yeah. Thank you, Vanessa. I won't let my 90-year-old mother drive, but I still have to deliver her wine to her. Yeah. Yeah, I mean, if she has a problem with it, then stop delivering it to her. I don't.
But once she gets to
you become her supplier.
Your driller. So it's.
Yeah, what can I do when someone else is the enabler that helps support their use? I'd have to know a specific sort of instance in that. If someone else is enabling them, I can't ever make anybody do anything they don't choose to do, whether it's whoever's using or whoever's supplying them. But I can definitely have that conversation and let my opinion be known to both of them that, maybe this person isn't the best person for you to be hanging around. They're not helping you. Okay. But explain it to them, and then that'll be their issue. Too much coffee and caffeine. How does that get to be a mental disorder? Good question, Faye. Good question. You'll have to take that up with the APA. Okay. I don't know how me smoking a cigar every day, or maybe having too much tea in the afternoon, could put me in the mental category either. But might give them a talk on that. I'm not going to defend it. Resources for counseling for family members affected by the addict. They have Alcoholics Anonymous for Narcotics Anonymous, whatever it happens to be, 12-step groups for the user. They also have groups for the family members, and that is
Al-Anon.
Al-Anon, right? Yes, Al-Anon is the resource for that. You can go there. One of the things about 12-step groups is it helps people by dealing with other people who are going through the same thing that they are. So many times when I go to a Al-Anon meeting there or a Narcanon meeting, whatever it happens to be, is I'm talking to people who struggle with the same problem I have, so they can oftentimes give some good suggestions for me and what have you. So that may be one. Or the Psychology Today website, they have resources for whatever town you're in. You may find a counselor or therapist there. Al-Anon.
And did you see that there's 3 of them in the Q&A?
Okay.
And Henry, as he's doing that, I have uploaded a few times, and I would do it again, the link for the slides. I'll do that again, but you'll also receive them in the follow-up email as well.
Okay, does the physical lack of dopamine cause Parkinson's or present as Parkinson's? No, not really. That would be able to, you can diagnose those, you can separate those out. So no, it's not going to show. It's not going to show up that way. Does warning your kids about the family genetics and history of alcoholics help prevent it? It may. I mean, it's going to depend on the child and if they listen or if they don't. But it may definitely have an effect on them if they're, if they're open to hearing what you have to say. It can. What else would help for that? You might sit down and watch a movie like Omar and Pete, right, or one of these educational entertainment movies. I don't know that any of them there. Let me just caveat that. I don't know that any of them on that list are really for children. Okay, but maybe something. And even Omar and Pete, they're sort of. I mean, they're from the street, so they're going to talk like they're from the street. But the HBO series or something like that, sit down and watch those movies with them and talk about it. And, you know, I mean, the more you talk about it with your kids, the better off it's going to be. They're going to make their own choices, but at least help them make informed choices. And I get that's what you're sort of getting at when you tell your kids about your genetics and history of alcoholics in the family. You're giving them information that they can use, and that's really all we can give other people is information. Yeah, I mean, there are programs out there, you know, there and things like that help with those. But really, just sitting down and talking to them, maybe like I said, watching one of those movies together, watching some of the HBO stuff, or if they're a little older, maybe watching the Omar and Pete stuff. But really going through that and saying this is what happens. The Pleasure Unwoven one is a good one that can help like I said, helps physiologically explain addiction. So that may be when you're talking about genetics and the history of it in the family and things like that. That one may be more for that. But yeah, just talk about it. Just sit down and have a conversation with them. Make sure you leave the line open to talk to them about it. You know, I wouldn't encourage experimentation, but at the same time, if they do experiment, you can't, you know, disown them, right? Because then they're not going to tell you if they did or not, right? So, yeah, problems of parenting, right?
Yeah. There you go. Hey, could we go ahead and advance to the last slide then now?
Okay.
Good. Unless, and I didn't know if you had anything else. You're more than welcome to. I have a couple of things I want to add. If you have something else, did you want to have something else you want to say, Doctor, before I do that?
No, I think that's all I have. Remember that, you know, if I have a loved one who's in distress, what can I do right now to help them? Well, get them to a meeting, right? There are different meetings. There's AA for Alcoholics Anonymous, Narcotics Anonymous takes in a lot of stuff. They have some very specific ones, Crystal Meth Anonymous. If they're there, also they have some behavioral things, right? Gambling, Gamblers Anonymous, Sex and Love Addicts Anonymous. So they're all modeled on that 12-step group. There's usually a group somewhere close to you. You can Google the 12-step lines, and they'll tell you when it is and where it is and a phone number to call to get a hold of somebody. If you're looking for something to, you know, what can I do right now? What can I do today to help my person? Try to get them to a meeting, right? Try to get them to a meeting and then encourage them to seek treatment and go from there.
And depending on how big of a city you live in, I know where we live, there's a meeting going on every time, you know, pretty much every hour of the day, every day of the week. You know, you can find a meeting that works in their, you know, works with their schedule, I'm sure. I know some of you are joining us from smaller towns, and that may not be the case, but yes, very, very good. Somebody obviously added Celebrate Recovery on there too, which is, I think, is a good resource as well. Great. Dr. Mottern, thank you so very much. Great presentation, incredible. I want to talk about my loved one. Our next one that's coming up on the 24th. My loved one shows signs of social personality disorder. How do I manage our interactions? And so I want you to join us for that. We'd love to have you. I guess we probably need to do one on codependency, huh? That's probably a whole nother a webinar. I don't know, but codependency I know is a huge issue as well. And but I also want to make a comment. I realize a couple of people that have jumped to a conclusion during the presentation on a word that was used, and I want us to please be careful of that. You know, first of all, the criticism was taken out of context, which is something we need to be careful of. But you know, if you put yourself in the position of a presenter and you're presenting, I have said things from time to time that I regret saying, use the wrong word, the wrong thing came up. But for you to use a criticism as unprofessional, to call it unprofessional, that's really uncalled for. And I just want to ask you all to please be careful going forward, that you don't jump to conclusions like that and use that kind of thing. There's no reason for us to be unforgiving and that we have to call people out on things like that. So I'm just going to throw that out to you as we go forward. I certainly appreciate you all joining us. Dr. Mottern is donating his time to do this, and I'm so grateful to you, Doctor. Thank you so very much.
My pleasure.
Hey, you all have a blessed day, and thanks for joining us, and look forward to seeing you next time. Take care.
Bye-bye.